Let's look at how to interpret the guided progression analysis. Guided progression analysis shows us events and trends in the visual field. Here's a trend. Trend is upwards. We like that, makes us happy. Here's an event that makes us unhappy. Event in glaucoma visual field testing doesn't mean the day it happened, it means the day of the test. The event is we find statistically significant change. The trend is the rate of change over time, and we'll take a closer look at these. And unfortunately in glaucoma, there really are no happy events or trends. The GPA software event analysis shows statistically significant visual field change. The trend analysis shows us the rate of visual field loss over the entire time that we've been doing tests. The event is testing and looking at the current test compared to an established baseline. Change is reported if the test level at that new date is statistically significantly greater than the change that you would expect due to variability. For the trend analysis, it just plots all the fields and it lets us see clinically meaningful change. The baselines matter. Spend some time with the baselines. By default, the machine picks the first two fields, but if that first field was unreliable, throw it out. You should pick two reliable baseline fields and hopefully pick ones that you get relatively close together in time. You don't want to wait a year and have your baselines a year apart. I usually try to get 3 fields within the first year so I can start using the GPA software as soon as I've gotten that third field. Review your baselines. If the mean difference is greater than 4, if one of them's not reliable, throw it out. You also can reset baseline when there's an event, and I'll show you an example of that a little later. The elements of the GPA report will mostly be familiar. You'll recognize performance, grayscale, pattern deviation, and the glaucoma hemifield test. The new elements are the deviation from baseline and the progression analysis. Let's look at that report, and we'll spend a little time on this. Let's start by identifying some symbols. An open triangle means this one field shows progression. A half full triangle means 2 in a row, and a full triangle means 3 fields in a row show progression from the baseline. An X means the point is already so damaged there's no further analysis that can be performed there. So here we see the 2 baseline fields up above. The mean defect is similar. The reliability is excellent. So those are 2 good baseline fields. Right below that is the progression, the trend analysis, and you can see this is someone who's progressing. If we look at some of the details of the progression analysis, the slope matters. The software estimates the range of 5-year progression. In this case, it looks like the patient may have substantial progression. We ought to change therapy. The other thing we need to look at is age, because as physicians, we tend to underestimate life expectancy. If somebody's going to start dropping below 75% VFI, I think it's time to be a little more aggressive. Let's look at 2 examples. Here's someone who clearly has damage, but being followed over 7 years, there's really no progression. This is someone where I'd be reassured that our strategy for treatment is appropriate. Here's someone who was stable for years and then suddenly around age 70 started to decline. This is worrisome. Seeing this pattern tells us 2 things. It tells us that something's changed in their health. It tells us we need to be more aggressive about therapy. When you see this sort of bend in the curve, reset your baseline. So here we've set the baseline to when the beginning of the decline happened so we can better see the change over time. And if you look down in the right-hand corner, you can see that it is identifying the change that's also shown in the trend analysis. The VFI is a good predictor of visual disability. VFIs between 75 to 100% can be considered early, and there's usually not much disability there, although falls are greater as VFI decreases. By the time you're in the 50 to 75% VFI, you're visually disabled. Anybody below 50 has significant visual disability. So if you see that trend line heading down and you think it's going to hit 50 in their lifetime, it's time to be more vigilant and maybe more aggressive with your therapy. Let me show you the first time I really appreciated the value of GPA software. This is a patient I'd been following for years. She was a high myope. She had RK in the past. Her nerves were really anomalous. And I knew she had damage in that left eye. There it is. And I could look at her mean defect. I could look at the black boxes and the pattern deviation. And I was really trying to count the black boxes to look for change. We loaded the GPA software, ran an analysis on her, and I found that on my watch, she had been getting worse. Let's take a closer look. Here is the progression analysis. And even though many of the points were so damaged, I couldn't tell if there was progression, some of the points that were just moderately damaged were getting worse. This is an alert. I could not see this without GPA software. When I looked at her trend over time, it looked like relatively slow decline, but that's between age 48 and 58. What if she lives to age 88 or beyond? So we changed her therapy as soon as I saw those results on the GPA software. I find GPA helps me. It can show conversion from normal to abnormal, but the standard single field analysis can do that. It's essential, but it's not new. It can show progression as events, points that have gotten worse from the baseline. In essence, it's opening up that black box and letting us see when damaged points get worse, or even when normal points are just hitting the range of statistical significance but have progressed. The progression plots, that trend over time, lets me find people who have fast glaucoma. I try to estimate the risk of disabling vision loss, and I'll intervene based on that rate of progression and the life expectancy. GPA has extended my ability to see what's going on in the visual field. I find it a valuable tool, and I use it with all my glaucoma patients. So Rob, what do you do when you see a new patient? I'm glad you asked. If you look at the GPA software's utility, you really need the baseline, and it's only when you have 5 fields that you can truly unpack the power of the software. So I try to get my first 3 fields within the first year. You come in, we'll get a baseline field. If it's good, I'll see you in 3 months, and we're going to repeat your field. And I may do it at a 6-month visit after that. I may do it at the 1-year visit. Theoretically, you could put those first 2 very close together. And I wonder whether, for any of the other clinicians, have you changed your thought about how frequently you need to get fields or how to sequence them with access to GPA software?
Rob, you do similar that I do. I tell patients when they're newly diagnosed that I like to get 5 fields over 2 years, similar to how you do it. That time of diagnosis, 6 months, 12 months, and then I'll go further, 18 months and 24 months, so 2 years out, just because, as you said, you really need 5. Saying that if a person isn't reliable, I may need to get another one quicker. If I'm concerned or I see change earlier, so in other words, by the 3rd field, or for example, if you start to see change, I'm not going to wait 6 months. So I think the clinician always needs to be flexible. But the rough guide is you need a certain number of tests, which historically we used to say when we got a field once a year, it would take us 4 years until we're able to really tell if somebody's getting worse.
Don, how is GPA fitting for you?
I rely heavily on GPA, both for HFA and Cirrus. I just don't think that we're capable of integrating all the information from those fields. A common mistake among trainees is to look at the prior field and compare it to today's field, and you can't tell whether someone's progressing with that lack of longitudinal data. But I can think of 3 reasons why to get a lot of fields early. Murray showed an example of the learning effect. So you want to get through that learning effect as quickly as you can. Secondly, the GPA that Rob mentioned relies on two baselines and the data is merged. It'd be a shame to wait a year to get that second field and merge the two. You got to have two at baseline. And thirdly, there's a group of fast progressors, as Rob alluded to, and you're not going to pick them up if you just do one field once a year. It's going to take 4 or 5 years to get a GPA answer, and they could have progressed fast through the first year or two. So I think the GPA is incredibly important, but we should be doing more fields and certainly more fields at baseline.
And
Thanks,
if you
Don.
do enough fields early on, you may be able to back off on the rate of fields if in the stable patients. You might be able to do fewer fields in the out years because you know that that patient is stable on that treatment regimen. So maybe you get some back.
We've talked a little bit about when a field becomes abnormal and we initiate treatment, but we're now talking about progression. And I'll ask you first, John, what on a field makes you think that it's time to change therapy? What's the trigger?
Oh boy. Again, looking at these progression printouts. I mean, finding that change. I mean, repeatable change. Any repeatable change you find is a red flag. So, but judging just from fields whether it's time for an intervention or a change in therapy is not necessarily the right approach. I mean, it's a red flag amongst the rest of the data that you're collecting. Your view of the optic nerve fiber layer, the OCT as well. But certainly just looking for any repeatable change in the visual field is a big deal, a big part of that process.
Thank you. Don, I think it was you who really taught me or told me you can't look at today's field and the last field and know anything from that, can you?
That's right. Well, glaucoma patients progress generally very slowly. And if you're just looking at the last field, the thresholds for meaningful progression just haven't materialized yet. So that's sort of a rookie mistake, I would say.
I've made that mistake. So let me tee something up, because I threw out there the number of a VFI of 50% as being disabling, but that's really bad. When you're down to 50% in one eye, you're not functioning. What's an alarming VFI? Where do you think that number or threshold is? Mike, I know you've thought about this a bit.
I think that's a possibility. You said it a few minutes ago. If it looks like the patient is progressing at a rate which will put them at a VFI of 50 in their lifetime, then I think that's where 50% comes in. It's not, oh, they have 50%, I should start doing something. No, it's, oh, this patient's progressing at a rate which will get them to 50%, and in shorter time than I think they're going to live. And that's where that number gets useful. So when we designed the GPA, we said event analysis will wake the practitioner up. It won't tell them what to do, but it'll wake them up. Change is happening. Rate of progression analysis will give them a sense of the clinical significance of what's going on, and also a way of deciding how much they need to adjust the treatment. And 50% is the barrier. Second eye at worse than 50, you have a severe disability.
So, yeah. So, Mike, I take a little different approach that I use a number 75%. That's kind of my border. And, somewhere around 75%, I believe is, or what, about 3 or 4 dBs on the mean deviation, maybe, is that correct?
It's about a -7.
Okay, -7. So I think there's enough data that shows that people start to have functional loss, whether it's driving, reading speed, walking, tripping, at somewhere around 2 to 3 dBs or 4 dBs. And I've always used that, and to me, the number that I don't want them to pass is at 75, because I've always felt that that's where people, number one, start to notice something's wrong with their vision. Glaucoma is no longer this this abstract concept. Now their life is changing, and I don't want them to go anywhere near there. So I will try to use that trend line. And one of the things that we John, I guess, kind of got into the event analysis, but the event analysis works when you have deep scotomas. But if they're a little shallower, it's really the trend that can be extremely useful. So I'll look more on, I'll look at that 75 number, and I will gauge that and then make interventions to try to prevent from crossing that barrier.
Yeah, we have the same philosophy. You just have a different number you're looking at.
Yeah.
And I'm thinking, look farther out, as Rob pointed out. If in their lifetime you think they're going below 50, then you got to sharpen your knives.
Yeah, but
providing we remember about changing baseline, when there's been a major intervention, or a change.
John, we had a question about that. Where do you reset that baseline when something has changed?
Well, I get you have to sort of follow, don't you, to see if it has actually leveled off after that surgery or the addition in medication. So, again, it's an iterative process, really, which isn't necessarily terribly helpful on a panel like this. But the important thing is that if you've had somebody that's in a steep decline and you manage to stabilize them, you don't want to be using the original baseline and continually setting off the red flag and making it look as though you're going to be reaching the 50% or lower the entire time you're with that patient, that you may have been able to stabilize them enough to bring that long-term rate of progression much flatter again.
Great. We are going to move on, and I see the questions accumulating. We're going to do a lightning round before the end, and we're going to try to answer every question you're posing.